In this lecture, we will discuss premature atrial contraction and how it would normally appear on the EKG. Premature atrial contractions, or PACs, are just as the name implies, beats that occur earlier than expected from an area in the atria outside of the sinus node. They are common in the fetus, infants, and children. Even when they occur frequently, they are typically benign and tend to decrease in frequency with age. So first off, why do ectopic beats come about? Well, there are groups of pacemaker cells throughout the conducting system that are capable of spontaneous depolarization just like the sinus node. The intrinsic rate of depolarization of these pacemaker cells decreases from top to bottom along the conduction system. That is, the fastest is in the sinus node and the slowest is within the ventricles. And the general rule is that the fastest pacemaker controls the heart. Okay, so if you look here, we have our conduction system. This is remember, our sinus node. And then from our sinus node, we have these internodal pathways, the anterior, middle, and posterior, that come to our AV node. We also have this Bachmann bundle coming to the left side of the heart, depolarizing the left atria. And then we have our His bundle coming off our AV node, and that splits off into a right bundle branch. And then we have our left bundle branch. The left bundle branch subdivides into our left anterior fascicle, and we have our left posterior fascicle. Okay, remember, the left anterior fascicle innervates the anterior and superior portions of the left ventricle, whereas the left posterior fascicle innervates the posterior and inferior portions of the left ventricle. And remember, these fascicles and the right bundle branch then go to our Purkinje fibers, which innervate the individual cardiomyocytes, and then the impulse spreads by that means. Okay, and what we're saying here, okay, is that the fastest pacemaker starts in our sinus node. Okay, so meaning that the fastest intrinsic rate is up here, and as we go down to our AV node, to our His bundle, to our bundle branch blocks and our fascicles into the Purkinje fibers, everything slows. And the general rule that you'll see here is that the fastest pacemaker controls the heart. Well, because the fastest pacemaker is in our sinus node, remember, the intrinsic rate is between 60 and 100 beats per minute. Okay, because of that, it will tend to control, and that's why we call the sinus node the default rhythm, or it sets it when we're in normal sinus rhythm. Okay, so normally we have these ectopic impulses that are like secondary pacemakers that are suppressed by the more rapid impulses that originate above them. However, if an ectopic focus depolarizes early enough, that is before the arrival of the next impulse, it may actually capture the ventricles, producing a premature contraction. These premature contractions, or quote-unquote ectopics, are then classified based on their origin. For instance, if we have a premature ectopic beat originating from within the atria, we call this a premature atrial contraction, as we'll see here. If we have a premature ectopic beat originating from the AV junction, we call that a premature junctional contraction, or PJC. And then we have premature ectopic beats that could originate from the ventricles. We call those premature ventricular contractions, okay, PVCs. So our focus here is these PACs, and these are the ones that arise from the atria. So you can see here in green, we have our ectopic focus outside of our sinus node. Remember, it's atrial, so it's happening in the atria. This one's in our left atrium, and notice it's pretty much firing faster than our sinus node, so it's taking over the pacemaking function of the heart. Okay, meaning the beat is originating from this area and heading towards and depolarizing all other areas of the atria and going towards the AV node. Okay, so why do they occur? Well, a premature atrial contraction occurs when some other pacemaker cell in the atria fires faster than the sinus node, as we've been saying, and this results in a complex that's coming sooner than expected. Okay, now one thing to note is that the premature beat resets the sinus node, and the pause after the premature atrial contraction is not compensated. In other words, the underlying rhythm is disturbed and does not proceed at the same pace. We call this a non-compensatory pause, and it should be less than twice the underlying normal P to P interval. Okay, so let's just erase some of this so we can just go over what's going on here. Okay, so look above, we have that rhythm strip. We see a few beats there. Okay, we have our normal sinus beats occurring. Okay, normal P to P interval, right, from one P wave to the next of the same point, and then we have our PAC, this one right here that's occurring. All right, so imagine we have our first beat coming from our sinus node, and same thing with our second beat. So this is the first beat, the second beat, and this third beat is the one coming from here. Okay, coming from there, notice we have a different P wave morphology. If this is where our P wave is coming, it should come at this point, although notice it's coming earlier, prematurely, okay? That's because this area is firing earlier than our sinus node and at a faster rate, okay? So that's what's going on in our PAC, and then we go back to our normal rhythm, right, with our sinus P waves here. All right, but remember, one thing we said is this is a non-compensatory pause, meaning once this fires, okay, this PAC, it's going back and resetting our sinus node. In other words, here's our P to P interval we said from here to here, okay? We said the next P wave should come here, and if we follow that cycle, it should follow and fall at this point. But notice that it doesn't, okay? It doesn't fall there, and instead, after the PAC, we get a different reset of our sinus node, and it starts at its own interval, okay? If it was compensatory, it would mean it would compensate for this PAC and fall where it normally should, okay? But we call this a non-compensatory pause. Now, a few other things to note are that the P waves in premature atrial contractions are often have a slightly different morphology, as we said, from those of the sinus beats. And this is because the origin of the premature contraction and its conduction through the atria are not exactly the same as those originating from the sinus node, right? So if you erase, so we can see this here, right? Look at our P waves coming from our sinus node, okay? Notice their morphology. And then we have our PAC, this one right here. Notice it's a different morphology, okay? So it's coming from somewhere else in the atria, and because of that, it won't have the normal sinus P wave morphology. Now, the PR interval may be slightly prolonged compared to sinus beats, which is likely because conduction is not occurring through the specialized atrial conduction tracts, or the PR interval may be normal or even short. It really depends on the origin of the premature atrial contraction. Remember, AV nodal conduction makes up the majority of the PR interval, okay? So again, we have our beat coming from this place, okay? So it's going towards our AV node, and depending on how far it is, all right, if it was coming from this point, it may have a shorter PR interval. If it was coming from all the way over here, okay, use this color. If it was coming from that, you'd maybe see a longer PR interval. Okay, so again, the PR interval is based on where that origin of that impulse is coming from, the ectopic focus. All right, now the QRS complex remains normal and narrow, similar to the sinus beats, except for the overall timing of the complex. Okay, so again, everything, once it gets to the AV node and gets through there, everything below here in the ventricles is occurring normally, so we should have normal intraventricular conduction and normal QRS complexes, all right? Now I want to go through our chart here so we don't miss anything, all right? So again, we said premature atrial contractions is when the pacemaker in the atria fires at a faster rate than the sinus node. We said the general rule is when the fastest pacemaker controls the heart, okay? And in this case, it's coming from an ectopic focus within the atria. Remember, we said it resets the sinus node, and because of that, we get this non-compensatory pause that has a P to P interval that's less than the 2 times, okay? So if you imagine, here's 1 time, okay, and this would be the 2nd time, and notice that it's coming sooner than that, all right? So it's less than 2 times the normal P to P interval. Some of the causes that you may see premature atrial contractions are anxiety, myocardial ischemia, hypokalemia, hypomagnesemia, medications such as sympathomimetics, caffeine, beta agonists, digoxin toxicity, okay? Anything that's increasing that. Increasing the automaticity of some of these ectopic foci within the atria will cause these to occur. Now, we said the clinical significance of these are common. They decrease with age. They're typically benign, and some patients may actually have palpitations with them, okay? So it's not common to have them, but some may actually have them. And again, because of these premature contractions, we'll see that they can actually trigger reentrant tachyarrhythmias, okay? When we start talking about AV nodal or AV reentrant tachycardias, we can see that these premature atrial contractions can kind of be triggers of them, all right? Now, in terms of the regularity, it's an irregular rhythm. Why is that? Well, it's because we don't have constant intervals between this, right? We see the intervals that are changing throughout because of that premature contraction, okay? Remember, regularity means that the intervals between each one will be the same if they're regular, but in this case we don't have that, so we have an irregular rhythm. The rate, remember, it depends on the underlying rate of whatever is going on, okay? Usually you'll have this PAC and then the rate will continue, okay? So because of that irregular rhythm, remember when we find the rate of irregular rhythms, we have to count the number of complexes going across the standard EKG, multiply that by 6, okay, and then that should give you the rate in beats per minute. In terms of the P wave, we said the morphology and the axis will be different, all right? So remember, our normal axis of our P wave should be heading this way between 0 degrees and positive 75 degrees. However, if you have one arising, let's just clear this up here. If you have one arising in the place that we're saying here from this region, maybe it's heading somewhat this way, okay? So it won't be in our normal region. Or you may have one coming at this point where it will head backwards, okay? We call that retrograde conduction. So that's something we'll talk about when we talk about junctional rhythms, all right? Now, so the morphology in the axis will be different from the normal sinus P waves as we saw here, all right? There would be one-to-one conduction of the P waves to QRS complex. So even though it starts here, once it gets to the AV node, there should be no issue and it should get through to the ventricles and we should have no problem there, okay? In terms of the PR interval, we said that it varies depending on where it comes from, okay? If it's coming close, if it's originating close to our AV node, it may have a shorter PR interval. If it's coming farther away, we may have a longer PR interval, but it will otherwise be normal outside the PAC. Okay, so all our intervals in our normal sinus regions should be normal. In terms of the QRS width, again, everything below, once it gets to the ventricles, all the interventricular conduction will be normal, so we should have similar QRS complexes to the underlying rhythm. There sometimes could be grouping, and we'll talk about this shortly with the nomenclature, and there should be no drop beats. Remember, all these P waves that get through, the atrial depolarize and it get through the AV node, the His bundle, and conduct through the rest of the ventricles. Okay, so now I want to end with this nomenclature that you'll sometimes hear about. Okay, so we can classify these premature atrial contractions into unifocal or multifocal. Okay, when we talk about unifocal, that means it's originating from one area. Okay, so we have one area within the atria that are causing this premature atrial contraction. So imagine we just have this one green ectopic focus firing, and because of that, if you were to see multiple waves of them, you would have similar P waves throughout. Okay, so imagine you'd have this times 3 or how many ever times it came from that area. Now when we talk about multifocal, we're saying that there are multiple areas within the atria that are having these premature atrial contractions, okay? So more than one area, and because it's coming from more than one area, we will have different P wave morphologies, different PR intervals, different P wave axes, and so forth, okay? So we call that multifocal. When we talk about bigeminy, trigeminy, and quadrigeminy, this means that we're having complexes occur at different times, okay? So imagine, in this case, we're only looking at one PAC, but imagine we had a PAC occurring, okay? Imagine we had PAC, and then we had a normal beat, okay? And then we had a PAC. Because it's happening at every second beat, so every other beat, we call that bigeminy, all right? Now, if we were to have a trigeminy, what that means is every third beat would be a PAC. So imagine you have PAC, normal beat, and the third beat is a PAC. We call that trigeminy. When we talk about quadrigeminy, this means that every fourth beat would be a PAC, okay? So maybe a PAC, 3 normal beats, and then 1, 2, 3, the fourth beat is a PAC, so that's quadrigeminy. All right. Now, when we talk about couplets and triplets, what this means is that you would have 2 of them occurring in a row. So imagine you have a normal beat and a PAC and a PAC and then a normal beat. This would be a couplet. Okay. Now imagine you had 3 in a row. We would call that a triplet. Okay. So just some nomenclature that will help you, and you may hear about them, and just good to be aware of. Well, that's the end of this lecture. It was a longer one than we normally have, but I think there was a lot in there that you can take away that will help us as we move forward. We discussed premature atrial contraction and how it would normally appear on the EKG. I hope you learned something.